Welcome everyone to our town hall on reframing childhood fall prevention. Today's event is facilitated by the National Advisory Committee on Childhood Fall Prevention. My name is Michelle Dukeman. I'm a member of the National Advisory Committee and I'm the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute, Canada's national charity dedicated to injury prevention. Before we begin, we'd like to start today's presentation with a land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous people, Canada's First Nation, Inuit and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights and title of Indigenous people of Canada and declare our respect of Indigenous elders, past, present, and future. I would ask that everyone takes a moment to themselves to acknowledge the land where they currently reside. Next, I just want to cover a few housekeeping items. Participants will be muted throughout the presentation, but once we begin the discussion portion of the program, participants will have the opportunity to be unmuted if you wish, so that you can share your thoughts and your perspectives, but you're also welcome to share in the chat box as well. So you don't have to be unmuted, you can just share your thoughts and perspectives that way if you choose. If you do have a technical question, please do use the chat box, or you can use the raise hand function, and we'll be monitoring the chat box so that we can assist you. The session is being recorded. The slides and recording will be emailed to all registrants in a few days, and they'll be posted on Loop Junior as well. Now I'm going to hand it over to Hélène, and she's going to tell us about today's purpose and some expected outcomes.
Hello, everybody. My name is Hélène Gagné. I'm the Director of the Fall Prevention Program at Parachute, and welcome. Today, we will be discussing reframing of childhood fall prevention and potential future opportunities and priorities for action. And we hope that we come out of this town hall and that we develop a common understanding of the progress to date and on the reframing of the childhood fall prevention in the Canadian context, as well as identify collective actions that we could take together, and by being specific on who, what, how, and when we can move forward on this issue. Next. First, we will cover three areas today in the agenda. So there'll be a brief recap of the work that's been done since the last town hall in 2020 and prior to that. And then we will be highlighting the proposed broader approach to childhood fall prevention, and then we'll go into the guided discussion. But first, I want to acknowledge everyone on the National Advisory Committee on Childhood Fall Prevention who's been working for many years on this issue and who's been following up with the work between the last town hall and today, and organizing the town halls as well, and who has been integral in developing the broader approach that will be presented to you. But first, we want to hear about you.
Thanks, Hélène. I'm going to launch these a couple of polls just so we can see who's joined us today. So I'm going to launch this first one. Apologies to if there's anyone from the territories or the Atlantic provinces, Zoom only allows you 10 options. So, oh, sorry, we're moving forward. So I've had to bundle the Atlantic provinces and our territories, but if we do have anyone from those groups, please feel free to share in the chat specifically where you're from. All right, 100% participation rate, perfect. I'll share the results so that you'll be able to see. We've got a good group from Ontario, Manitoba, and Alberta. So hopefully we can connect with any of the missing areas of Canada at a later date. The next poll is about whether you attended the September 2020 Town Hall on Childhood Fall Prevention. So I'm going to launch that. Alrighty, so it's good that we're doing a recap of that town hall, a brief one at least, but we've got a lot of fresh eyes here today, so that's exciting, and excited to hear from you. I'm gonna do one last poll. And so wanting to know how much of your work is related to childhood fall prevention. So there's some scale from all of my work to none of my work. So I'll let you answer that one. All right, so the majority of you said a little of my work, and then some of my work and all of my work. So it'll be interesting to think back to this question after we talk today to see if your perspective on that changes. So keep that in mind. But for now, let's move forward with the program. And we're going to talk about work to date. So I'll hand it back over to Ellen.
Great. So as Michelle mentioned, it's relevant to go through some of the work that's been done in the past, considering that many of you have just joined and weren't part of the first town hall. So to better understand the issue of falls among children, we conducted 2 environmental scans, one of which was in 2019 and the other one was in 2020. And briefly, the scans provided an overview of the nature and scope of fall-related injuries in children. And it included 21 key informant interviews to understand the issues that were faced by the practitioners in the field. So this is what they told us in terms of considerations for this work. They said, keep in mind that there are differences between falls in older adults and children. So they vary in terms that often enough we expect children to fall as part of their healthy child development, and it's to be expected. We have a little bit of that in the older adult range, but more so even so for children because of the healthy development. But that brings to the question of severity and of injuries due to falls. So should we tend to all the falls? And the answer to that was that we should really focus on falls that lead to serious injuries only and not scrape and bruises. And there's a recognition also that in terms of falls among children, there's a different level of resourcing and prioritization that occurs. The other part the other considerations, definitely the silos, and this is not news to any of us, and they vary on many levels. So may they be organizations, jurisdictions, and mandate, and we should keep that in mind. And the issue of balancing risk and play. So what we heard is that there's a lack of consensus on many of the concepts covered under childhood fall prevention, like for instance, risky play, active play, physical literacy, and how these concepts are distinct from each other, particularly when it comes to practice. So that may lead to different messaging to parents in terms of what constitute risky play and active play. So in light of healthy child development, so it makes it difficult to know what action to take, when, how, and by whom. Another consideration that is to take into account is the at-risk populations. So the burden of injury is higher in at-risk communities, including falls in children. There are many safety issues in at-risk communities, from intentional to unintentional, and there are housing, crowding, traffic issues. So there's an importance of couching fall prevention in children in the broader context of community safety and well-being. And they were also mentioned that we needed to address some practical challenges. I won't name them all, but some of them were like, how do we get the attention of stakeholders working in active living sector? How do we identify the stakeholders working in this field specifically? Because as some of you work a little bit, others full time, and some of you is some of the time in this field. So how do we identify stakeholders? And of course, the ever-ending issue of resourcing and prioritization is another one. And how to make the information culturally relevant and that addresses local community context. So that's what came out of the 2 scans. Next slide, please. So as we mentioned earlier, we conducted a town hall in September 2020. And it was to validate the findings of these scans and to determine the next steps for collective action. And these are the issues that came out that there was a fair consensus around. So there's a need to redefine childhood falls and their implications. So suggestions that were made were like, how can we have a common or unified definition of falls? And can we situate falls among children under a broader approach, which we have, and we'll talk about just in a few minutes. And of course, bridging the existing silos we just mentioned and focusing on those falls that lead to serious injuries. Another issue that came up was branding. So there was a consensus that we should find common messages across Canada on this issue, and that we should have a national media campaign of some kind that would reduce the pressure on local resources, and that would be very inclusive of all communities, including at-risk communities. Another key component that was highlighted by the participants at the last town hall was the need for knowledge, information, and skills. So of course, data and falls indicators were mentioned, and we'll hear that there's some work that's been happening since then. So we'll have a bit of a presentation on falls indicators coming shortly. And the need for national standards and best practice programs, there are a few in between. And again, just to reiterate the fact that we don't always know who works in this field and at what level, and a clearer and more effective communication around this issue is required, as well as engagement strategies with various stakeholders across sectors, not necessarily just in the fields that are currently engaged. And finally, during that town hall, we asked the participants to let us know about the current assets at the time and the opportunities which they listed. I won't go through that, but those are the opportunities and assets that we're building upon with this work. So now I will leave it to Kathy to walk us through the work that's been done since that last town hall.
Thanks, Helene. For those that don't know me, I am Kathy Belton, and I'm with the Injury Prevention Center in the School of Public Health at the University of Alberta. And I'm very happy to be here and happy to be involved with this work. So building on what Helene said, following the last town hall that we had in September of 2020, the National Advisory Committee took on a role as a central convener and leader for the implementation of next steps. We created a summary of the town hall findings and recommendations and sent that out to all the registrants. The advisory committee then began meeting on a bi-monthly basis as an entire committee to explore ways to reframe childhood injury prevention using all the observations and recommendations gathered to date. A designated working group was developed to meet between the bi-monthly meetings to move key action items forward and to flesh out a proposed framework, which you'll see later in this meeting. The National Advisory Committee planned today's town hall and has kept abreast of new developments in childhood fall prevention in the last 2 years. And I'm happy to say that we're going to highlight 2 new initiatives in this field, one from the Public Health Agency of Canada and one from Public Health Ontario. And with that, I will hand it over to Andre to talk about the initiative from the Public Health Agency of Canada. Thank you.
Thank you, Kathy. Hi, everyone. My name is André Champagne. I'm an epidemiologist at the Public Health Agency of Canada. So there I work on the injury and suicide surveillance team. So I just wanted to take this opportunity to briefly mention our upcoming 22 report on pediatric falls, which may be of interest to you. So in the report, we are looking at fall-related injuries from 3 different data sources, namely from the agency's Canadian Hospitals Injury Reporting and Prevention Program, also known as CHIRP. And from this data source, we're actually looking at fall-related injuries dating between 2011 and 2017. So for some that may not be familiar with the CHIRP program, so CHIRP is a injury and poisoning surveillance system operating in 21 different sites across Canada, 11 of which are pediatric hospitals. So the focus of CHIRP is basically collecting data on the circumstances of injuries and poisonings that are presenting in emergency departments. So the program does so by collecting the account of the injury and poisoning that is presenting at the emergency department. And so we ask the patient or the patient caregivers, as well as hospital staff, to describe the injury. So what happened, how did the injury occur, where did it take place, when did it take place, and were there any external factors involved, such as substances? So in the case of falls, did someone push this patient, and so forth. So additional clinical information is then entered by the hospital staff, and that's more of so clinical data. So for instance, we look at, they enter the level of treatment. So was this patient admitted? Were they treated in the emergency department? What was the nature of the injury? Was it a fracture, a head injury? And were there any substances involved, and so forth? So the two other data sources are coming from the Canadian Institute for Health Information, namely the Discharge Abstract Database, which collects information on hospitalizations across Canada. And the second one is the National Ambulatory Care Reporting System. So today, there are 2 provinces and 1 territory, so Ontario and Alberta, and the Yukon Territory have complete full coverage. So with that, that provides an opportunity to present population level estimates related to injuries that we're studying. So for our report, our target population was children between the ages of 0 and 9 years. Next slide. So now I'll just briefly provide some quick highlights from our CHIRP database. So between 2011 and 2017, we extracted 315,000 injuries involving children aged 0 to 9 years. And of those, 58%, or roughly 182,000, were categorized as falls. So a pretty significant number. So in our report, we are presenting information based on the 182,000 cases that we captured. So among the 0 to 9 age group, the 3 leading mechanisms were same level falls, falls from furniture, and falls from recreational equipment. Of course, we're mindful that these mechanisms vary by age group. So following this high-level chapter, we have subsequent chapters that present breakdown by age group, so more relevant to specific age groups. In terms of the nature of injuries, so we found that open wounds, fractures, and minor head injuries consisted of the majority of injuries sustained by this age group. And in terms of location, homes and school settings were the most common. But again, we are mindful that this obviously varies among different age groups. So next slide. So this is a quick graph showing the distribution of falls. And again, this is CHIRP data. So as you can see, the toddler years definitely represents the highest proportion of cases, really peaking at the age of 1. And then we see a decrease as children get older. But also what's apparent on this graph is the sex difference as well that we noted, where males represented a higher proportion compared to females. And this pattern seemed to be pretty consistent across ages, but less pronounced as children get older. Next slide. So when we created this report, we were trying to find a balance between the amount of text in the report, as well as providing some visual content to convey what we wanted to the readers by just looking. So just an example of an image that we provide in pretty much every chapter. And this is an anatomical breakdown of the injured body parts percentage-wise. So as you can see, So this actually consists, so this is the 0 to 9 age group. So the head and face consisted of the majority of these injured body parts, but we also broke it down to upper and lower extremities as well. Next slide. So I did mention that, so with the CHIRP data, we have hospital staff fill in clinical data, and this is an example of such. So the level of treatment is also reported, so that kind of helps us. So this variable helps us with kind of gauging the level of severity of these cases. So for instance, among children 0 to 9 years, we found that 62% required treatment in the emergency department, whereas 4% required to be admitted at the hospital. So a smaller percentage, but still significant finding, just considering the severity of these cases. Next slide. So as mentioned, so we were mindful that fall information certainly varies on depending on the age groups. So in subsequent chapters, we do break it down by age groups, and the information we do present is so the location where the injury took place, the area which is more specific to the location. So for instance, the injury took place in a home. We're in the home, so either in the washroom, living room, basement, or so forth. We also present context of the injuries, the body parts affected, which I kind of presented 2 slides ago, the nature of injury itself, and as well as the level of treatment, which helps to kind of gauge on the level of severity of these cases. So this is pretty much, obviously this is a quick highlight of the report, but I just want to present what's to be expected in this report, and I am leaving you my contact information should you have any questions, and thank you for listening.
Thanks, Andre. We'll pass it over to Alexia now.
Perfect. Thank you very much, Michelle. Hello, everyone. My name is Alexia Medeiros. I am an epidemiologist in injury prevention at Public Health Ontario, and I'm going to be speaking to you on our work today, both on behalf of myself as well as my supervisor, Dr. Sarah Richmond, who is the injury prevention lead at Public Health Ontario, but was not able to be with us today, but was very integral to this work. So currently in Ontario, only emergency department visits, hospitalizations, and mortality due to falls are indicators that are systematically collected and reported on in the pediatric population. And while, of course, these are important for understanding high-level burden of fall-related injuries, they weren't as useful for developing interventions and program evaluation. And because of that, the Ontario Child Injury Prevention Network indicated a need for indicators that better served their work in fall prevention and were more proximal to the work that they were doing. And in that, they also requested some technical resources to guide the use of indicators. So next slide, Michelle, thank you. In order to respond to that request, we went through several phases. And the first of that was a peer-reviewed and gray literature search of indicators that exist both in Canada as well as internationally across all health sectors. What we found from that process and the list of indicators and fed it back to our stakeholder and expert groups that were a part of that injury prevention network, and engaged in an iterative consultation process to refine this list. So that involved both recommending indicators that maybe weren't identified in the literature, refining ones that already existed, or removing some that were deemed not really important for the work that these stakeholders were doing. And then after that, we were able to specify these indicators to form technical resources, which I will show you in just a moment, as well as we're able to populate one indicator that was prioritized, and that was the serious injury hospitalizations due to a fall. And I will also speak a little bit more on that as well. So the results of our consultation process and literature search were these 13 indicators, broadly categorized into outcome and policy indicators. The outcome indicators describe, some of those burden ones that we talked about, as well as some more specifics around the context of a fall. So for example, its place of occurrence, as well as the policy indicators, which were about compliance with safety standards and some higher level systemic action towards fall prevention initiatives. So that was the result from that process. And from that consultation with stakeholders, we identified that serious pediatric injuries related to falls were really important. As Helen mentioned, of course, falls occur during childhood, during natural child development. And so we don't necessarily want to prevent all falls, but we do want to prevent the most serious falls. Go to the next slide. So that was our main rationale for this. Also, an indicator already exists related to pediatric injury, but not specific to fall-related injuries. And just generally, there was limited data concerning fall-related injuries in the pediatric population. But most importantly, it was identified as important to distinguish serious injuries from all fall-related injuries that were expected during childhood in order to really develop interventions that prevent the most serious outcomes. Go ahead, sorry, next one. So in order to do that, data was acquired from the discharge abstract database, which Antoine mentioned, and it was used to examine fall-related hospitalizations in Ontario among children and youth from 2010 to 2019. And then in order to identify the serious fall-related hospitalizations, a selection of ICD-10 codes that was previously identified, or defined rather, were used to define the serious injuries. So those include things like open head wounds, facial and neck fractures, as well as a whole bunch of other various serious injury outcomes. And then the rate per 100,000 population of serious fall-related injuries in Ontario was calculated and then categorized also by age group and sex and mechanism of injury. Next. And so these were the high-level results of that. So we identified that in Ontario in that time period, over 26,000 fall-related hospitalizations were observed, and among those, about 3,600 were defined as serious fall-related hospitalizations. The most common mechanisms of those serious fall hospitalizations were from skis, blades, bikes, and boards, and most commonly occurred among the male adolescent age group 15 to 19. So these were just the high-level results of that. We were also able to, for all of the indicators that I showed you previously, able to create these indicator specification tables. These were derived from work previously done in childhood injury research to guide the use of these indicators. So these include, a little blurb on why they're important and how they should be used, how they can be calculated, what data is needed, and where that data can be found. As well as recommendations for potential stratifications. So in our conversation with stakeholders, something that came up a lot was understanding how these injuries distribute by socioeconomic status or other levels of marginalization. So we included that as a recommendation for a potential stratification for a lot of these indicators. Also geographic location is of course useful for intervention planning, other demographic characteristics, but of course these recommendations are not exhaustive. And finally, also each table includes a limitation section to identify where limitations of the indicators exist. And yeah, so these are available for every single one of the indicators that we identified and are to be used as a technical resource. Finally, we have one next step to complete this project, and that is the indicator pilot. So we are hoping to pilot one indicator, most likely to be this serious injury indicator, among a subset of public health units in Ontario, and hopefully in having stakeholders use this indicator in their work, we will be able to collect feedback on its use and identify opportunities for refinement. So my last thing here is I will use this as a bit of a recruitment call. If anybody here works for a public health unit in Ontario and is interested in potentially working with us on this next step or just wanting to know more information, I encourage you to email me. My email address is right there, and we would be pleased to hear from you to participate, or even if you're just interested in the work. And that has been our work to date so far, so thank you.
Excellent. Thanks, Alexia. I'm going to now hand it over to our next presenter, and I think that's Steph. Yes, it is. Okay, great.
Hey, hi, everyone. I'm Stephanie Cowell. I'm Director of Knowledge Translation at Parachute. And I think Michelle and I are going to, in tandem, present the next couple of slides to you. So, of course, when we're thinking about addressing an issue, we want to understand the size and the nature of the issue that we're talking about. And we heard a little bit about this from Andre. That was a nice little preview. The data that we're going to talk about on the next couple of slides is pulled from the infographic that you see on your screen. Don't worry, don't be squinting. We're going to zoom in on the sections in just a moment. But all of these data come from Parachute's Cost of Injury in Canada report released in 2021. So when we think about falls in childhood, when we look at the data, we see that these have just an immense human and economic cost. So among children aged up to 14 years, falls are the #1 cause of injury, hospitalizations, emergency visits, and disabilities. So when we're focusing in on injury priorities, this is certainly one for the age group. And there's an economic impact as well. So injuries related to childhood falls cost the economy close to $1 billion every single year. Out of this, 665 million are direct costs to the healthcare system for things like physician services, rehabilitation, ambulance transport, and the like. So Michelle is going to dig a little more into what these numbers mean and where these incidents are coming from.
Awesome, thanks, Steph. So now that we've talked about the economic cost, let's think about how that translates to the human cost. So in a single year, falls among children result in over 5,800 hospitalizations, almost 298,000 emergency department visits, and over 1,600 disabilities. We also know from what Andre told us earlier too, that the mechanisms of serious injury from falls, they differ by the top causes, differs between age groups. So for our youngest age group, 0 to 4, it's falling from furniture. For children aged 5 to 9, it's falling from playground equipment. And for children aged 10 to 14, it's falling while using skates, skis, or boards. So clearly, there's no denying that serious injury from falls is a huge cost to the healthcare system, the economy, but also children, families, and communities affected. And speaking of communities, if we take another look at those top causes of serious injury from falls, we notice that these injuries happen in a variety of settings. They're at home, at play, in the community, at school, and those settings and sectors are supported by a variety of integral people that have day-to-day interactions with children, like teachers, coaches, childcare professionals. So kind of all of this is reinforcing the notion that childhood fall prevention goes beyond supervision in the home, and it also presents an opportunity to intervene at different levels. So now I'm going to turn it over to Robin, and she's going to expand on this idea a little bit more.
Thank you, Michelle and Stephanie, for going over the infographic. My name is Robin Stewart. I'm with the Saskatchewan Prevention Institute, located in Saskatoon, Saskatchewan. My role here is the Child Injury Prevention Program Coordinator. As was mentioned earlier, we want to move away from childhood fall prevention operating in its own silo while gaining a deeper understanding of the issue and addressing the challenges. With the aim of simplifying the concept of childhood fall prevention and linking it to other issues and broader sectors, we created this simple visual with the hopes of helping more professionals identify their role in childhood fall prevention. By connecting falls to the broader concepts of community well-being and children's safety, we would like more professionals to see how their work directly links to childhood fall prevention efforts. We believe this goal is present in many sectors where professionals may not be identifying fall prevention as a goal of their work, yet they may be working in children's safety and children's well-being, which we know is closely linked and likely overlaps with childhood fall prevention efforts. So the details in the center of this visual are directly taken from the infographic which Stephanie and Michelle presented. Both causes and consequences are included here to highlight that we're focused on unintentional life-altering injuries and deaths. Michelle, next slide, please. So we used the design of the concentric circles to highlight that fall prevention is the responsibility of the whole community, including individuals at the center and all the way out to broader systems that influence everyone's safety and well-being. Of course, with that, we always want to highlight that children's safety is not the sole responsibility of one parent or caregiver, but rather a combined effort of the community as a whole. We want to recognize that systems and policies impact children's safety and well-being, and therefore childhood fall prevention. Ideally, we want to engage key stakeholders across all of these systems in a collaborative effort that allows us to identify and overcome the barriers to improving children's safety and community well-being. So with that understanding, what we're proposing is simplifying the way we talk about childhood fall prevention while also broadening the understanding of how childhood fall prevention fits into the work already being done by many professionals who work with children and families in both downstream and upstream efforts. We've given you quite a bit of information, especially since most of you were not at the previous town hall. So we just want to have a quick opportunity for questions on what we've already presented, and then we're going to move into some discussion on next steps.
Great, thanks, Robin. So yeah, if you have any comments or questions, please feel free to type them in the chat box or use the raise hand function if you have something to say. But yeah, if you will just give you a couple moments to kind of simmer in that and let it soak in a little bit. And then we'll go on and start discussing a little bit more. So here's an opportunity to ask any questions. All righty. Let's move on to some discussion prompts. So as I mentioned before, you can use the chat box to answer some of these questions that we're going to pose, or you can use the raise hand function, and I'll be able to enable speaking for you. So whichever you choose, that works for us. So I'm going to hand it over to Chantel to facilitate these next couple of questions.
Thanks, Michelle. Hi, everyone. Thanks for having us here today or being part of our conversation today. I'm Chantal Walsh, a health promotion specialist at Child Safety Link in Nova Scotia. And I have a co-host here with me for these questions, these guided questions. Cynthia, would you like to introduce yourself as well and walk us through the first three? May have lost her. I'm not sure if she's still there or not. Okay, well, I'll jump in and certainly.
Sorry, can everyone hear me okay? Oh, great. Okay, I was talking and maybe you didn't hear that. So good. Hello, everybody. My name is Cynthia Menzies. I work as the injury program specialist with injury prevention with Manitoba Population and Public Health. I'm dialing in from Winnipeg, Manitoba, and we're going to invite you to join our discussion time right now. But before you do that, I just invite you to maybe shake your hands out a little bit, since the first question is on well-being. Place one hand on your heart, one on your belly, and take a deep breath in. And exhale, you're opening up some space to really think about outside of the box solutions. So in the first question, I'm going to ask, in your field of work, and this could be what you're doing right now, or even what you're, lending a hand in or having a reach toward, how do we create a connection between community well-being and childhood fall prevention? Just thinking about how that felt, even that connection that you made with your heart and your gut, that feeling of well-being, and extending that above and beyond the work that you're doing into the field of childhood fall prevention. And as you're thinking about that, you feel free to use the chat log. Automatic writing is really good to kind of get some ideas flowing. We don't mind. Whatever comes out is important. Let it flow. And if you'd like to share through the microphone, maybe just indicate. We'd love to hear from you either way. not sure if there's any, oh, there we go. I can see. Is there anything coming through in the chat? Ah, here we go. So I'm hearing from Lilia, this is respect to, like, was this respect to this question here, sharing the cost effects of childhood falls, working with our municipalities to develop safe public policy? Brandy, it starts with physical activity that is developed in childhood and supported across the lifespan. Thank you. These are really great responses. I can move to the second one. Does that sound fair? All right. What other, okay, here we go. What other initiatives have similar mandates and goals around preventing childhood falls leading to severe injuries? So thinking about things that already exist that have similar mandates and goals around preventing childhood falls leading to severe injuries. Think about like age-friendly communities, participation, initiatives that focus around physical literacy. Okay, we've got something here from Rihanna, conducting more education awareness programs for community members for fall injury prevention. And Brandy, embedding physical literacy in the development of physical activity skills that would include school, community, sport, and recreation.
Just some great answers.
Yeah.
That embedding piece is so huge too.
I have a question. It's Elaine. I know I'm part of this committee, but is it the issue? One of the issues is that often enough there's this perception that preventing falls in children is kind of a individual, like we mentioned it briefly earlier, that it's upon the parents' shoulders to figure out. So how do we change this way of thinking? How could we approach that? And I say we in a very royal way, because it's that's part of the question too. Who should be involved in this?
Yeah, and it does extend to the next question, was who needs to be a part of this work as we reframe childhood fall prevention, so we can combine those two for sure.
So that the ownership isn't just on the parents or caregivers in that regard.
Yeah, that's helpful to have this just visual, just as a recap.
So is it because I'm looking at this diagram, which is great, which I have to say that because I'm part of the committee, but it is great because it does show where we're more familiar, which is the part of the childhood fall prevention, whereby we do, have most of the knowledge where it comes to children's safety and going into different spheres in the community and reaching out. There might be various levels of awareness and knowledge, and definitely in terms of municipalities, it's probably some select ones that have some kind of knowledge or intervention of, or the ability to do something about falls in children.
Mm-hmm.
That's a good way to frame it, Ellen, because I think if you think of it that way, it might provide a bit more get thinking more about how they can all sort of intertwine and relate to one another or influence each other.
We've got Robin. For me, I'll read what you wrote, Robin. For me, I think agencies such as Scouts who do respect and sport training, which touches on physical literacy and injuries.
There's a comment there as well from Allison. There's an increased focus on addressing concussion in sports and rec, not through individuals and parents, but on those organizations as well, sport and rec organizations.
So I guess for me, that would be a concussion. And I know that there are some people working in the concussion area here, hint, hint, Steph. So because, and I know there's an intent to expand preventing concussions that broader than outside of sports and recreation. Is it the part, my question would be, because it makes sense that as we saw from André, where the injuries occur for children, it's mostly the head when they're toddlers, because, you know, it's bigger, it's, you know, they're falling. So is that when we look at concussions and specifically with children, is it because it's not in the purview of sports, or is it being addressed in that realm, and how do we connect with that realm of the work? Steph, would you have something to say about that?
I guess, sorry, in terms of non-sport for younger children who aren't at that age yet, or just non-sport in general?
Both ends.
Okay. Yeah, I mean, I think, you know, certainly we've seen sport is where there's the greatest amount of infrastructure that's been put in to address concussion. So in terms of policies, procedures, things that can be tracked. We've also seen specifically in Ontario that also applied to the school setting, though primarily to school sport. So I think it's one of those questions. It's where it's kind of similar to how when we look at how workplace injury prevention has been so successful when we compare it to other types of injury prevention. It has such a space where there can be that infrastructure put in. So, you know, outside of that system, what are the ways or where do we have access to get information out and spread it through? And I think, you know, one of the reasons that we're here today is particularly when we're talking about younger children, we don't necessarily tease out all these different things. It all comes down to how do we create, you know, safer environments, whether it's, you know, in or outside the home, that allow children to develop and explore and take risks while also preventing serious injury. So I think it's the connecting that comes together. So whether it's the fall would result in a head injury or a different type of injury, we want to prevent that serious injury. So how are we preventing falls from heights in the home through buildings or products or information sharing? Again, probably a really indirect answer to your question, but I think this all these threads and this interconnectedness is why we're here today to figure out, okay, we've been trying to separate, I think, fall prevention in children as its own thing, but we need to look at it more holistically. And I think looking at the types of injuries that result, like head injuries, is part of that.
Steph, just building on what you said, especially around infrastructure and buildings, Allison's comment in the chat, the settings of built environments around stairs and window guards to prevent falls, points to municipal and provincial policies and standards for key roles in this area.
Yeah, exactly. And I see Brandy's comments. And Brandy says, I'd love to see us look at injury issues from a competency protective lens. What we do to help prevent concussion is the same as falls, but we divide everything to our own detriment. And as someone who's often asked to present on concussion prevention, it's a bit of a challenge because outside of sport, which has some very specific interventions, often it's how do we prevent concussions? We prevent the causes of concussions, which the leading causes are falls and motor vehicle crashes. So that takes us back to fall prevention and road safety and the things we do in injury prevention. So you're absolutely right, Brandy. In preventing injurious falls, we are inherently preventing concussions and other head injuries.
Chantel, do you want to move to the next question?
Certainly. There's a few more responses coming in for this last one, but I'm happy to move on to our next. I know we'll capture all of the responses that we are receiving. So definitely encouraging you to keep those answers and responses coming to the following questions that we have. So building off of the first three, now we want to dive a little bit more into the how and how are we going to do some of this with what your great suggestions were. Our next question is, how do we engage and reach those who need to be a part of this work? So we're looking, essentially for some ideas or suggestions on what comes to mind as far as engagement, who needs to be part of these discussions or part of this important work, and how best to reach those people or those organizations or those other people we need to have and to continue these conversations to go forward.
We have a response in the chat from Melissa that sort of answers some of what you're asking here, helping to educate parents, educators, and children how to identify risk factors in their environment and how to overcome them while still providing the opportunity to engage in play. It kind of cut off here on mine, but
changing the language around risks when speaking with children, from the be careful, that's too high, to how are you feeling right now? Yeah, totally in agreement with that. And I've caught myself as a mother doing that exact thing, going to that be careful culture that's established and then stopping myself and realizing that no, actually encouraging perhaps a feeling that they have for them to be able to assess what they're doing and if it's risky or not, has really provided some benefit there. And then I see here our Healthy Babies, Healthy Children program addresses injury prevention with our families with school ages 0 to school entry. That's wonderful to hear. I know that that's probably evolved over the years, so it's nice to hear that that's still on the radar, because that is definitely an important piece to include in those early development pieces as well. Okay, those are great. If we move to the next question that we have. So from how we're engaging and who needs to be part of, to where should we start in taking this action? How could you or your organization or both contribute to some of that action and those actionable pieces? It's a loaded question, but certainly we're getting some great responses, just kind of alluding to some of that work. So how could we begin to start taking some more actionable action as a collective or as more of an individual? And it's hard. This is as a person who's worked in this area, fall prevention, for quite some time, it's definitely a challenge to start to continue to build some of those pieces of, okay, where is there actionable work to be done? How are we going to move that forward? So I'm right there with you in the silence, but certainly there's no wrong answers. It's more so just continuing the conversation to see if maybe we can land somewhere that is a directional step.
Helen, you have your hand up.
Yeah, it's, and I know that it's kind of the obvious one, but the sense of urgency in light of many other issues that are occurring in this world at the moment, it doesn't seem to be there, and it feels like it's a catch-22 because we're asking who should be involved so that we can create the awareness, that we can raise a sense of urgency, but at the same time, it comes back to why is it not already a sense of urgency when we see the data being presented by André and by Steph and Michelle, and having, you know, most of the information already at hand. So one of the actions would be like that sense of urgency in terms of, it comes back to a bit to awareness raising, but I would like to think that it's a little bit beyond that as well.
Yeah,
Mhm.
definitely. I think there's this is a pure assumption, but I think that there's a lot of, well, someone else is going to do it, or someone else is working on that, or just kind of passing that off like that. And I think that that's where that lack of urgency, that sense of urgency you're speaking of, Hélène, is where it comes from in a lot of ways, because there's so many unknowns. There's so many knowns, but there's so many unknowns as well that it's hard to even know where to start at times. But I do see some information coming through here, just about a lot of parental conversations through programming, the 0 to 6-year-old, which is a nice age range. Typically in the fall prevention world that I'm in, we kind of look at the 0 to 4 falls in the home, but I like that 0 to 6. So expanding some of those age ranges, I think, would be very, very valuable. The co-worker on leave is our rep in our Provincial Injury Prevention Committee. So contributes to our health information website that we promote to parents and the public. That's wonderful too, getting that information out there, because keeping it at the forefront of our minds is what's crucial as well to continue that conversation and propel it forward. Creating a handout for parents to receive at their wellness checks from their child's doctor with their little ones, 12-month appointment. Definitely a good suggestion as well. I know there was a lot of work here in Nova Scotia in the past anyway, being done when it came to child passenger safety and that relationship between doctor and family. So I think there's opportunity definitely to create something similar if it came down to fall prevention in the home. So great. Lots of good ideas circulating. So it's what we like to hear. It's very helpful. Okay, so if we were to move on then to our final question for today, just as part of this discussion piece, what motivates you to participate in collaborative action? We're looking sort of from a singular, a personal standpoint. What essentially are some of those key pieces involved that really help you and motivate you to participate in moving some of that collaborative action forward? See here, we have a couple of responses coming in.
Randy had an interesting comment around around shifting safety language, and the example she had provided was collaborating with recreation programmers, where, you know, so many children engage in leisure activities. I really like that, shifting safety language.
Absolutely, that is a great one. A lot of discussion today too about that relationship and forging that relationship between recreation and other. So I'm taking that away from today as certainly it's been definitely on our radar, but it's one of those things that I'm hearing come out a lot from today's discussion. So incorporating that into some work in the future.
Another great comment around looking at a built environment. Let's see where I just saw that there, and the industry as well for harm reduction approach to injury. So healthy built environment, a very key area with this work.
Definitely. See, as a parent and child health coordinator with the health authority, child development, health, and safety are priority. It's so great to talk when you're chatting with folks who work in this area too, right? Because it's almost a no-brainer, like that they go together, but then it's much more difficult to go out and make those connections and linkages out in the outside world. It's not as straightforward to see it. So these are all really great. Thank you very much for just participating in, and we certainly will welcome more continue to put some of those answers in the chat as they come to you throughout the remainder of our time today. But also if things pop up in the interim, by all means, reach out and let us know what some of the things that have come up from these questions today might be for you. That would be really helpful. Build feelings of security, safety, and confidence in the knowledge of one's own physical abilities and limitations. I really like that. We do have to do really or better with that for sure. I know that that's one of our goals and one of our places that we come from when we try to frame some of the work that we're doing in fall prevention. So thanks for sharing that. And I believe now, if again, continue to pop some answers in chat into the chat box there, but I do believe we are now going to hear about a few of our next steps from the National Advisory Committee.
So there are a few things that I think I've pulled from the discussion, and I think we'll be able to pull some more with review. And feel free to add to this if you're hearing something different than what I've heard. I'm hearing pretty consistently that we want to provide accessible and holistic information to stakeholders at all levels. So that municipal level, all the people that surround the families we work with, so coaches, schools, family support workers, as well as the caregivers in the family. I think it's been mentioned several times that we want to include how to overcome risks while still providing opportunities for exploring and risk taking and finding that balance. And I believe that we're kind of talking about creating a informational handout that could be used at multiple levels or maybe different ones for each level of what's pertinent. Those are the next steps that I think we can pull from this discussion. And I think when we review all this, there may be more. So we will take all the comments and discussion points and report back to the group. We will continue this work at the advisory committee and share some actionable goals. Does anyone want to add kind of any other next steps that were pulled? Ellen, you have your hand up.
Yes, as I'm playing with my buttons here, yes. I wonder if people are comfortable putting that in the chat room, is that what is it that you would need, not just from the National Advisory Committee, but in general, to facilitate your work in preventing falls in children? So because some of you, I heard, have a little bit of your work in this, others complete full-time, and others part of their work. So what is it that you need? And because we've heard the new developments, we have new data, we have new indicators, we have some information of reframing childhood fall prevention. So what else would you need to move this forward in your work?
Hi, Helen, if I can just jump in here. I think I heard some requests for resources that could be used by family physicians and pediatricians to talk to parents about child fall prevention, keeping in mind that balance between protecting our children and allowing them, some healthy development opportunities. So if I was wrong, somebody please correct me.
Yeah, Michelle, great comment. Maybe you can say it out loud.
People haven't heard my voice enough today. No, so yeah, I was just thinking about kind of a two-pronged approach, because it definitely sounds like from the chat there's a desire for kind of educational resources for the physicians and those more clinically involved with childhood fall prevention, but also a desire to shift thinking. Maybe not for the general public, but for those people that we talked about earlier, of those day-to-day interactions. So the rec staff and the coaches and the teachers, and maybe having an awareness campaign on some of those ideology shifts that so many of you mentioned in the chat, and made really good points to that degree.
We do have an annual opportunity with the Fall Prevention Month, and I know it's called the Fall Prevention Month, but is there something that can be done collectively whereby we could expand? At the moment, I would say it's people who are already involved and know of the Fall Prevention Month, but I talk about all provinces and territories. So how could we use this opportunity to raise the issue, but in the broader context, and yet using the Fall Prevention Month too? Oh, there's a need about the data here. I don't know, Andre, if you have something to add to what is being asked. Some people work in trauma and they need better, more to-date data on severe injuries from pediatric falls. Will that be in your report, Andre?
Okay, can you hear me?
Yes.
Okay, perfect. Yes, so yeah, I didn't mention this. So in our report, we actually break down the mechanisms as well. So for instance, so Michelle, you mentioned windows, so we don't actually have a focus on that. But so some chapters include furniture, recreation equipment, stairways, nursery equipment, fall from caregivers, grocery carts, which we saw enough cases in CHIRP, falling from trees, ladders, bleachers, as well as balconies. So that's a focus as well. I just realized my camera was not on. There you go. So yeah, that'll be part of the report. But I definitely agree with you. You know, just writing these reports and actually detailing on some of the circumstances, then tailored approaches, prevention approaches can be done. So very good point. Yeah, we'll keep working on that for sure.
All right, so if anything else comes to mind, please feel free to drop it in the chat box. I know Steph put in there, where do we start with connecting to recreation? Do those linkages exist locally? And I think that's a great question, because I know for myself, kind of, and for some of the folks in this group, they may feel that we're kind of flying 10,000 feet above the issue, and potentially people on the line today are more kind of on the ground, and they might know of those linkages that they're using locally. So if you have any insight into that, please let us know, and we could use those. Someone else writes, safety equipment. We think your parents / caregivers would value, such as gates and barriers, window locks, harness, safety locks, self-reflective traffic waistcoat, helmet, and plug protector. Yeah, those are good items to list. Well, I'll let you put any other thoughts you have in the chat, because we'll be recording those. But I'll just provide a reminder that when the event has ended, you will be redirected to Zoom and invited to participate in a short evaluation survey. So you'll just click the blue button on your browser and you'll be redirected to that survey. So if you fill it out, we would really appreciate that for your feedback. And then also another reminder that if you aren't already a member of Loop Junior, please do sign up and we can keep you up to date and connected as this work moves forward. That's probably the best place to keep up to date as we continue this work and take all your great suggestions and try to come up with some actionable next steps. Also want to thank my fellow presenters for all your time and for showcasing all the great work going on in the childhood fall prevention space. And obviously, I want to thank everyone here today for your insights and your perspectives and expertise. It goes without saying, we really can't do this without you. We really want those involved in the childhood fall prevention space to have a voice in the way we move forward. So thanks so much for your time and for your energy. We really appreciate it. As a reminder, the recording and the slides are going to be available soon, and we're going to start summarizing your feedback and solidifying our next steps, and we will share that with you. But unless anyone else has anything else to add, I will bid us adieu, and I hope everyone has a wonderful rest of their day, and thank you again for taking the time and joining us today.